Specialist Dr. Navdeep Singh Pannu.
Hi, thanks. Thank you very much. This is quite a difficult job to be the last speaker, especially when after lunch and close to 4 o'clock already. Okay, so the topic today, I prefer the word now, time is of essence. The reason being because fertility is something which needs to be dealt with as soon as possible, especially when the couple is a younger age group. Because the longer they wait, the more challenging it becomes. So the problem affects 15% of couples. Out of that, 30% male problems, 30% female problems, 30% both have problems. So basically it's 50-50. The olden days, we used to think that the lady was the cause of the problem, but no, nowadays it's well established that the problem is on both sides. Okay? And 10%, we do not know why. We call it the unexplained. The problem is basically a delay in getting kids. They prefer to start a career first, or they prefer to go for a holiday or buy a house or things like that. By the time they decide to have a child, they'll be closing the age of 40 and things will get even more difficult. Stress, lifestyle. The biggest problem nowadays for us is cigarette smoking. That really destroys a lot of eggs and also sperms. The other one is, some people, they know they have a problem, but like obesity, polycystic ovarian syndrome or something like that, but they do not want to get it checked for fear of finding out something else. So in this, time is not your friend. Time can fix a broken heart, but not fertility. So a couple who comes into your practice who has been married more than 12 months or a year and been having unprotected intercourse, basically been trying for some time, then you should refer them to the fertility doctor. So the reason why I advise couples to hasten their process of getting a baby is because, you can see, as the woman ages, the effect on the normal eggs they have tend to reduce with age until they attain the age of menopause. The second slide shows you the risk of, the fertility drops and the risk of miscarriages increases. So anything between the age of 20 to 35 is the best time. This is a chart showing the embryos that were created by IVF. You can see the normal embryos that after age of 37 tends to drop markedly. Hence, that's the reason why we advise couples that when you get married, as soon as possible, probably have a holiday for 6 months, then you've got to start trying. So, when we see a couple who is unable to conceive, there are 4 main things that we check to find out why they're having a problem. And number 1 is the sperm count, the sperm analysis. It should be done 3 to 5 days after abstinence. There are 3 main things that we check, which is concentration, it has to be more than 15 million per ml. Your motility, at least more than 40%. And something called the normal morphology, it has to be more than 4%. So you see, you just need at least 4% normal sperms to get a baby. Okay, so our analysis in our center is a very busy slide, a lot of things that we check to ascertain what is actually wrong with the sperms. But the 3 main things that I mentioned is your concentration, motility, and morphology. So the 4 main things which affect the sperm counts is, number 1, smoking is number 1. Unhealthy food. Heat, especially with tight underwears and all. Infection, basically sexually transmitted diseases. So these are the things that we have to advise them and, well, no smoking, lose underwear at least, lose weight. Weight has a very important role to play, okay, in the quality of the sperms. And the easiest thing to do is give them some antioxidants. That's all that they may require. Okay, ACE, zinc, selenium, coenzyme 10, it's more than sufficient, unless they have other problems like varicocele, okay, or obstructive issues, then they might have to see a urologist to get it sorted out. The next would be for the woman. We have to do a transvaginal ultrasound scan. During this time, we assess the womb wall for fibroids, polyps, We assess the ovaries. We look for something called the antral follicle counts to see whether or not they have a good ovarian reserve or not. And to rule out things like cysts or any abnormalities in the pelvis. Okay? And the next will be, this is what we look out for. As you can see the good count, you can count how many eggs that they have. 1, 2, 3, 4, 5, 6. So this is a good count. This is usually a lady in the age of about 30 plus. And once they have gone into the perimenopausal age, okay, above age of 40 and all, then you see the number of eggs tend to reduce markedly. Then we know we're in for a challenge. So this is the other spectrum called the polycystic ovarian syndrome patients, where they have lots of eggs, but they don't ovulate regularly because of a hormonal imbalance. The next thing that we check for, the other things that, of course, the fibroids, the ovarian cysts, all these need to be assessed and corrected if they plan to conceive. Not all fibroids or cysts need to be operated. Okay, fibroids which are small, less than 2-3 centimeters, which are lying at the womb, outside the womb wall, we call it the subserosal area, then those are the ones that do not need to be operated. However, those affecting the inner cavity of the womb, the submucosal fibroids or huge intramural fibroids, yes, those preferably need to be removed to improve their chances. And we prefer the laparoscopic method because faster recovery, lesser bleeding, and they can get on with their plan to conceive or get a baby as soon as possible. The other one, to assess the inner lining of the womb, we do a hysteroscopy when we suspect that they have a submucosal fibroid or a polyp. In this scenario, we have to assess and look at the womb cavity and ensure we remove all these things before we go on to other fertility modalities. The third test that you can do is the blood test, hormonal blood test for the female partner. This is generally done on the second, third, or fourth day of the menstrual cycle. We prefer to see the levels of the follicular stimulating hormone, luteinizing hormone, okay, the other things like prolactin, thyroid, all these things, or sugar, fasting serum insulin, especially in patients which are obese or have polycystic ovarian syndrome. Then you have to do all these things, correct them first, then it will be much more easier to help them conceive. Lately, there has been a lot of talk about the test for ovarian reserve, which is important. We use it in every patient of ours, especially those who want to do IVF, to determine the appropriate dosage of medication. It's known as the anti-Mullerian hormone. This hormone is very high in young patients, and as you get older and older, you lose your good eggs, it will slowly decrease in number until a point where you know for sure this lady is already heading towards menopause and they probably need much more injections or a bit more treatment and help to conceive. So as you can see this chart, this is another reason why we advise couples between age of 20 and 35 quickly start a family. Okay, as you can see, the levels tend to drop gradually until the baseline, at the age of 50. Finally, the four things I mentioned: sperms, blood tests, the ultrasound scan, and the next is the fallopian tubes. The fallopian tubes are very, very important. Usually, a lot of doctors prefer not doing it because they feel it's invasive. But trust me, it will save the patient a lot of time and a lot of money. Because a lot of times, we prefer to start them on something less invasive. Okay, just try some, go for a holiday 6 months. Some patients have told me that they have tried clomiphene citrate tablet for 6 months. And then when they come to me, I just get the test done, and you know what? Both tubes are blocked. So we have actually wasted 1 year of the patient's life. Hence, in my practice, I generally do all these 4 tests at the first sitting itself. And then I can individualize their treatment at the onset. This is some of the, so as we know, the radiologists inject the dye between the day 8 to day 12, the menstrual cycle. Okay, we advise patients to abstain from intercourse before the HSG because we fear that they may have conceived or be pregnant during the procedure. Okay, and by the way, HSG has other benefits too. The first benefit is you'll know how the inner lining of the womb is, whether is it abnormal, uneven. Secondly, a lot of patients, I'm quite sure you've heard, that after the HSG, the next month, they conceive naturally because it has some physical activity where it pushes in, flushes open the fallopian tubes. Okay? And one man a few years ago who came in my office, he was very angry that after the x-ray, his wife did not get her menses. Okay, and he wanted a baby fast, so I called her in, I did a scan, and I saw a baby inside. So these things have happened many, many times after HSG, and that's it, they conceive. So it has other benefits too. But most importantly, if the tubes are blocked, then you just have to do an IVF for them. Okay, these are some of the pictures that this is a patient who had multiple. This is a patient from Africa who had multiple DNCs done. Okay, so there are a lot of scarring inside. And this is another patient from Malaysia. She has only one side. Okay, known as the unicornate uterus. The other method that we have to assess the fallopian tube is a laparoscopic surgery. But as this is an invasive procedure, we rather do this procedure if the lady has other problems to solve. For example, she has a polyp where we need to do surgery to correct the inner lining of the womb, or she has an ovarian cyst or fibroid. Then you can do this procedure at the same sitting. These are a few medications which, if you wish, you can practice this in your setting. There are a few multivitamins which are important. The first thing is the folic acid, as we know. That reduces the risk of the patient to have a baby affected by neural tube defects, brain, skull, spine, problem more than 70%. The other one is vitamin D. Vitamin D has been used quite regularly nowadays in the fertility line because it improves the chances of conception and it improves the overall pregnancy outcome. So we advise the dosage of 800 to 2000 international per day. But of course, if you want free vitamin D, then you can go out in the morning sun once a week for about 10 minutes, you get about 10,000 international units. But I think I'm quite sure none of us have time to go out in the morning sun. Okay? The other thing would be like patients which has high insulin resistance. Like as I mentioned, the patient with polycystic ovarian syndrome, we can start them on metformin. Okay, as it's not for diabetes, you're not going to bring down your sugar, so you can gradually increase their dose to about 500 milligram 3 times a day or 850 milligram twice a day. But there are side effects with these medicines, especially your GI effects, diarrhea, nausea, So I generally treat most of my polycystic patients, okay, with metformin. The other thing would be the most famous drug that has been around in the 60s is clomiphene citrate. This tablet is very, very convenient to use, easy to use. The side effect profile is nearly minimal, okay? But everyone's a bit worried about cancers. But it's written as the risk of cancer when you use clomiphene citrate is basically theoretical, okay? There has been no cases published where directly related clomiphene citrate. Okay, so end of the day, it's very easy to use, and this is how you use it. You can give the patient 50 milligram once a day, about 5 days. You can gradually increase it in the subsequent cycles to 150. If 150 doesn't work, then probably forget about it. But please call the patient back to your center to assess their ovarian response, their follicle response. Because if you don't see an egg growing with 50, then you know the next cycle increase to 100, then the next cycle 150. And if you still don't get, don't have any follicular development or they don't get pregnant, then they need to go to the next step, either a gynecologist or a fertility doctor. Now, if all else fails, then it's intrauterine insemination or IVF. In the intrauterine insemination, IUI, this is basically a method of choice when the husband's sperms is below average, because then you can concentrate the sperms, okay, and inject it directly into the womb. This is how we usually do it. I still use chromate tablets or letrozole as an alternative, okay, from day 2 to day 6. And alternate day, I give a very low dose of follicular stimulating hormone, because this helps to grow the eggs and much better follicular development. Then I bring the patient in on day 10 to day 15 to assess their growth of the eggs. And then we give them this injection called a HCG, and 32 to 40 hours later, we perform the IUI. So we call the patient in, we give us a medication, day 2 to day 6, so alternate day we give them injections. We scan them during the cycle, but once or twice to check for development of the follicles. Once they have minimum at least one. We don't like to go more than, we don't like 3 or 4 eggs because then there's a risk of multiple pregnancies. 1 or 2, it's fine. Okay. Subsequently, when you get an egg which is more than 18 mm, then we trigger ovulation with a HCG injection. And subsequently, husband has to produce his sperm, preferably in the clinic itself, okay, after 3 to 5 days of abstinence. Because if you have a husband who comes in 2 weeks of no intercourse and he comes in to give his sperm sample, the morphology and motility will be greatly affected. Or you have a patient who had intercourse yesterday, the night before, in the morning coming in for his IUI, then the numbers will be poor. Hence, we prefer 3 to 5 days. Okay? So we spin the sperms, we process them, and then just like how you do a pap smear, okay, we put in a speculum to visualize the cervix. Then with a smooth catheter, we inject the sperms into the womb. Now, for those who do this, I would advise you all to ensure that your patient has a bit of a bladder, because when you do an ultrasound scan, you will notice that the cervix has the uterus has straightened out. So it's much more easier for you to cannulate the cervix. If that too fails, so the success rate for that is about 15 to 20%. And after 2 or 3 attempts, either the doctor gets depressed or the patient gets depressed, then we jump to IVF. Okay, so the success rate I mentioned is 15-20%. After 3 attempts, the cumulative success rate is 45 to 60%. So it's a modality worth trying because it's less invasive, less stressful, and less costly. But after 3 attempts, you don't get pregnant, you better jump to IVF instead. Okay, so the IVF success rate, depending on age group, is 40 to 70%. The older you get, the lower it is. So average 40 to 70% in overall all age groups. Okay, but 60+% in most of the time. Okay, so day 2 to day 6, we'll give them injections to grow their eggs. We bring them in for a scan, then day 6 to day 7. Then we continue injections up to the 11th day of the cycle. Usually the 13th day of the cycle, we will retrieve the eggs. And this will be under sedation or general anesthesia, because it's a very painful procedure. Okay. Then the next day, we'll inform them regarding how many eggs that we retrieved and how many eventually fertilized. We prefer to do the transfer at day 5, called a blastocyst. Certain centers do it day 2, day 3, but day 5 is the best because only the best of the best embryos survive to day 5. And our success rate is much better that way. This is how we retrieve the eggs. We give them sedation. Okay, and we put in a transvaginal ultrasound scan with a very thin, long, fine needle, and we'll aspirate all the eggs one by one. And the same day, the husband has to give his sperm sample. As I mentioned, 3 to 5 days of abstinence, then we use his sperms. Some patients have a logistic problem. When I say that, we had some celebrities who didn't want to be seen in the clinic, so they'll come at a different time, because some politicians who did the same thing too. Okay, or some patients with a businessman, they're very busy businessmen, so they do not want to be, they have no time to come into the clinic on the day of the retrieval, okay, because all depends on the growth of the eggs and the menstrual cycle, so they can't afford that time. Hence, what we advise them to do is to come in the clinic, okay, whenever they want to, and freeze their samples. All right, then once you have done that, then we can start stimulation of the wife, retrieve her eggs, and use those frozen sperm samples to fertilize the eggs. Okay, or if the husband has a very bad sperm count where he needed surgical retrieval of the sperms, then we may have to freeze the sperms too. The surgical retrieval generally is done by a urologist. Okay, where we give them anesthesia and we do a small procedure, like a small incision, and retrieve their sperms, and send it to the lab for freezing, like cryopreservation. Some patients, they have a problem where they had done previous IVFs where they have failed the normal fertilization. So to ensure fertilization has taken place, we do something called like ICSI, where we take one batch sperm and inject it directly into the egg. Hence, we ensure fertilization has taken place. So this is how an embryo looks like. A day 3 embryo has about 8 cells, and the day 5, called blastocyst, is the best of the best embryos for transfer. 2 weeks later, we do the pregnancy test. In the interim, the patient will have to take medications to make a womb more favorable for pregnancy in the form of pessaries or tablets or creams. And then we bring them into the clinic and we do their blood test to confirm that they are pregnant. This is a small short video about how an IVF is done. Okay? So as I mentioned, on the second day of the menstrual cycle, we assess the patient and start them on the injections. Then we start them on FSH injections, follicular stimulating hormone. Sometimes we give them something called LH, luteinizing hormone 2, at the same moment. Then we bring them in to do a scan 2 or 3 times during the treatment to assess follicular growth. We prefer, well, more the merrier. So about 10 to 15 eggs is just nice. Anything more than 20, 25, 30, then it's overstimulation. It has very undesirable effect called ovarian hyperstimulation syndrome. So once the eggs have reached a nice size, which is 18 mm and above, then we give the final trigger injection known as the HCG. 36 hours later, we take them to OT. Okay? And this is what we do. We do a transvaginal scan with a very fine needle. We aspirate all the eggs until we have taken every single thing. Okay? So as I mentioned, this is done under anesthesia or sedation. It's all daycare. They come in the morning, about 2-3 hours later, they are home. Okay? So we have to aspirate all of them and send it to the lab for assessment. Okay? Then on, it's all in the lab. So the embryologist is the one which will babysit the babies. Okay, so we'll put them on dishes like this called wells. Okay, and we'll pour the semen sample and incubate those and wait for fertilization. Or we will proceed with ICSI, where we catch one best good-looking sperm which is running actively around. Okay, and we inject it directly into the egg to ensure fertilization has taken place. So this is how our first day embryo looks like. So this is when we call the couples, tell them, okay, congratulations, you got about 10 growing babies. Okay, and then we culture them day 2, day 3, up to day 5. Now, at day 5, that's when we transfer we do an embryo transfer. Okay? Now, embryo transfer is done the similar manner as how we do the IUI. We insert a speculum inside. We need a filled bladder, and we do it under ultrasound guidance because we need to place the embryo at least about 1 centimeter away from the fundus of the uterus. That's the best place to transfer. Because anything higher than that, then there's a risk for ectopic pregnancy. Okay, you can still get ectopic in an IVF patient because sometimes some patients' womb tend to have a lot of contractions. Okay, they are contractile for some reason. So in spite of all the medicines we give them, so it tends to push the embryo into the fallopian tube or out. That's when and the cervix and all. So to prevent that, we give them a lot of these medications like progesterones and all. In certain group of patients where they have recurrent failures, we do not know why they failed it. The embryos look good, everything looks fine, okay, and or they had previous history of recurrent miscarriages, or in patients where both husband and wife are thalassemia carriers, okay, maybe alpha or beta. Then we have to do this test called the pre-implantation genetic testing. It's where we take the embryos, the embryos are created with IVF and how I explained just now, and then we take a small cell out from the embryo, and then we subject it to chromosomal analysis to ensure that it's normal. This is how it's done. So what we do is we use all this done in the lab by the embryologist. Okay, we have a small laser over there to cut the embryo. Okay, and we take a small cell, aspirate it, and then we subject them to test. And in patients like or with thalassemia. Lately, we had a patient with cystic fibrosis, any inherited genetic abnormality. We can rule it out by doing this test. So that's you can see the color over there, that's the laser cutting it. Okay. So there are a lot of concerns from patients who tell me, doctor, if you remove one cell, won't my baby be born without an arm, without an eye, or without a nose? No, no such thing. All these cells are not, they have not, their roles have not been determined yet. Okay? Hence, the babies will be perfectly normal. We do a certain test where we put the patient's sample and a reference sample inside, and then we can look at the report. So this is a sample of the report. So you know that this is a normal female, this is an abnormal female. Okay, I had a patient which has a certain genetic abnormality and all her embryos had it. So and that's the reason why, she couldn't conceive all the while. Okay, so just say you had 10 embryos and we subjected all the 10 to PGT. We found 8 to be abnormal and 2 normal. So we'll transfer those 2 into the womb, and then she has a higher chance of getting a pregnancy. So basically it shortened her time to pregnancy. Can you imagine, we had all the 10, we had started from A and the last 2 were normal, so we'd have gone through entire whole year and keep on failing, and the last one she would have got her baby. So by doing the PGT, it just shortens the time for pregnancy. So this is how a normal male looks like. Okay, abnormal female. See, when we do this test, we will check the number of cells. So see, there is an addition of 19 and the loss of 22. So that's why it's abnormal. So these kind of embryos, they won't implant, or they'll probably miscarry. Okay? There are other patients too where we have tried every single thing. We have tried IVS, we have IVF, and we have done a PGT, but they kept on failing for some reason. So then we subject them to this test called ERA, Endometrial Receptivity Assay, where it tells the doctor when's the best time to transfer the embryo, called as the window of implantation. Usually it's about 120 hours after we start the progesterone, but some women tend to be a few hours earlier and some few hours later. So I had this one patient lately who had done 4 IVFs and she kept on failing. So we did this, then we found that her implantation window is actually 1 day later, 1 day after the normal group of people. So hence, when we transferred those embryos at that time, according to the report, she got pregnant. So these are the test modalities which are not used the first time the patient walks in the clinic, but in patients which have got recurrent failures, the PGT, the ERA, all these things are very, very good tests to improve their chances of a successful IVF. So yeah, this is a chart how we look at it. So most of the time we transfer the embryos at day 3 or day 5, and we look at the implantation window. Sometimes some patients are in the post-receptive side, some in the pre-receptive side. So, but most of the time we always get it right. Last part of presentation is for women who do not want to have a child at the early stage. They for various reasons, like they have career, to move up and in the corporate ladder, or they want to delay childbearing for some reason, or those who have those who are going to undergo chemotherapy for cancer treatment. Then what we do for them, we cryopreserve their eggs, right? We freeze the eggs for future use. In this kind of scenario, when you retrieve an egg from a 25-year-old lady, then we can still use those eggs to get her a baby at the age of 40, 45 years of age. Okay, because the eggs in her will keep on deteriorating, but the womb will remain functional. Okay, and this is how you hear about people getting, delivering after the age of 50, 60, Okay, because the womb is still functional. And in this kind of scenario, we do exactly the same way how I explained just now, where we give the medication from the second day of the menstrual cycle up to the 11th day, and we retrieve the eggs. But here, there are no sperms to inseminate them, we just freeze them, called cryopreservation. So this patient has probably they're undergoing cancer treatment or something, and there are some patients for religious reasons do not want embryos frozen. Okay, do not want to create embryos, extra embryos that eventually may be discarded. Hence, they prefer to fertilize maybe 2 or 1 egg. Okay, and then if it's fertilized successfully, then you'll transfer that. The rest, they will keep it for future use. Okay, so, and as I mentioned this, yeah, it'll be transvaginal scan. Then, you know when you freeze ice in your fridge, in the freezer, you can get a lot of crystals inside. Okay, so when we use this method called vitrification, okay, we replace the fluid inside the cells with this cryopreservative. Okay, and there's no ice inside, so the embryo is like glass. So everything is frozen that way, and you can keep it till eternity. How long you want it? You want to keep it, and so hence it's a very, very good method to preserve your fertility in future. There was a concern some time ago about birth defects. Lately, there were 2 big studies which have been done which have refuted that. So birth defects is generally related to whatever chromosome abnormality that the patient has. So hence, we passed on toward to its offspring. If your chromosome is normal, there's a high chance that your baby is normal. So what we spoke about is we spoke about the 4 main things to check. Okay, in a couple who is unable to conceive, like the sperm, scan, blood, and the X-rays. All right, then we spoke about using clomiphene citrate, things that easily be done in your practice. Even IUI, for example, also can be done in your practice with plummet itself. Okay, and we do have a certain we do give some of our patients or some of the GP colleagues opportunity where we can process their sperms, the patient's sperms for them in our center, and then they can take it back to their center and inseminate into their patients. When we process the sperms, our embryologist does it in our lab. Okay, so we have a proper report and as to how good the sperm sample is. Any questions? How do you treat retrograde ejaculation? Yeah. We will tell the male partner, the husband, okay, to take an alkalizing agent for 7 days before the sperm assessment or before the IUI, and then he has to abstain 3 to 5 days. Then he has to ejaculate his sperm out, collect whatever he gets, and then urinate into a bottle after that. Then we will take that sperm, that urine sample, and we'll take out the sperms from there. And we'll process it, and then you can use it for intra insemination or even for IVF. Unilateral oophorectomy does not reduce your chances for fertility. Okay? Well, yes, of course, you ovulate left and right, but once you have done an oophorectomy where you removed 1 ovary, then you got 1 ovary which will be functioning every month. So the probability for reduction in fertility is not significant. Okay? Or else then the woman, if we say that there's a chance for infertility, then she got no eggs growing every month. So hence technically she'll be, end ovulation and or menopause. So it's not like that. So they'll be, if they have 1 ovary, it's sufficient to have a child. Okay, metformin does not cause hypoglycemia in normoglycemia individuals, right? So it's safe to use. The only problem is some patients have a severe gastrointestinal problem, gas and diarrhea, or bloated sensation. Well, what I generally do is I'll give them a short course of progesterones. I use norethistérone 10 mg BD for 5 days. 5 days later, they'll have their menses. So day 8 to day 12, that's when we can do the HSG. So it shouldn't be a problem. Sometimes, some patients, the radiologist personally, so you can tell them, look, can you please do the X-ray for this patient? Okay, I'm sure she's not pregnant because she's been on OCP or you have induced their menses. But otherwise, what I do is, because I prefer them to have their menses. So 5 days of progesterone, wait for 5 to 7 days, they'll get their periods. Then you can start counting from that day onwards, day 8 to day 12. Okay? No. If you had taken nuclear injection for 3 months, you will resume normal menstruation at least 2 months after the last dose of your leukrine. This is provided you have a normal, remember the 4 main things? You have a normal, your husband has a normal sperm count, and you have patent fallopian tubes. Then you can conceive naturally. Okay, now there's a lot of discussion about IVF or IUI patients. I generally allow all my patients to have a normal delivery unless there's a complication, example breech or poor progress or something like that, then I do a cesarean section for them. So the notion that all IVF patients have to go for Caesar is wrong, because after the patient crosses the 12th week, that's 3 months of the pregnancy, after that she's like a normal pregnant woman, okay, unless she is about multiple cesarean sections, the third time, what do you call that, the previous scars, we call that previous cesarean sections, or she has other problems, then yes, then of course you have to do a cesarean section. The other thing is that if they have a medical illness during pregnancy, for example hypertension, diabetes, yes, of course you have to deliver them by the 38th week if they are on treatment. And no, you can even induce them, not necessarily go and do a cesarean section for them. Cesarean section is basically for obstetric indications. Oh, catch a cold and asthma. Well, probably we can have a sweater for them in the tank. Okay, yes, the sperm quality and the sperm quantity will reduce. So if you have a 10 million sperms, eventually you'll have 1 million sperm which will be successfully thawed out. Okay, but as I said, you're only going to get what, 10, 15, 20 eggs. So out of 1 million, I'm quite sure you can get good looking 10, 15 sperms. Okay, because we'll have to use this method called ICSI. We have to catch one good looking sperm and inject it into the egg to ensure fertilization has taken place. Okay, the whole course of IVF all depends on the dose of medication that's required. An example, if you have a 25-year-old with a very good anti-Mullerian hormone, her doses of injections will be maybe 150 follicular stimulating hormone for 10 days, and you compare it to a patient which is age 45. So she will require to take 450 international units of FSH per day. So I would say the range can vary between 15,000 to 25,000. At average now, we have a package going on about 16,888, but I always advise my patients stand by at least 20,000, okay, if you want to do an IVF. Next. Oh yes, you can have twins with IVF. You can have triplets, quadruplets, anything, but the reason why you hear a lot of twins with IVF because a lot of doctors transfer 2 embryos inside, okay. A lot of centers used to put in 3. We stopped because we do not want triplets. Triplets has its own set of problems. Mother can't walk, it's huge and she's immobile, a lot of medical illness during pregnancy. And the worst thing, the most painful thing is losing the babies when they are small. At about 20 weeks, 18 weeks, you lose the babies. Okay? Hence, my practice, I usually convince my patient to put 1 at a time. Because why increase your risk? You already had a hard time getting pregnant. So a lot of patients will see on their friends or their neighbors' Facebook, oh, triplets, nice, 3 babies, 2 babies. But I tell them, you don't know what happened when she was pregnant. The problems that she faced, okay? Always, I prefer to transfer 1 at a time, but very rarely nowadays 2. 3, no way, I'll tell them to go to another center. Because it's very painful to see when they lose their babies at a very premature stage. Okay, is surrogate mother allowed? Well, by law, we're not allowed to do it in Malaysia, okay? Because the mother who delivers the child, or rather, the lady who delivers the child is the lawful mother. So you'll have to go to court to adopt your own child, okay? And then comes in the race and religion and things like that. So basically, it's not allowed in Malaysia, okay? No, partial thyroidectomy does not cause infertility. If your thyroid hormones are abnormal, you have to normalize it before getting pregnant. Yes, you can choose the gender of your baby, like what I mentioned, the PGT, pre-implantation genetic testing for any employee. And one of the, in the report itself, you'll see whether you'll know whether it's a boy or girl. This is before transferring to your womb. Okay, does Malaysia allow? No. In Malaysia, we can't do IVF for single parents or single couples. Any comments on a primary post-menopausal woman with IVF? Well, we have had patients who are menopausal. My oldest patient is 52. Okay, she just delivered 2 weeks ago. Now, when we see a patient after age of 45, we have to do a few things. One, cardiac assessment is mandatory. Okay, she has to go for a stress test, echo, all sorts of things to ensure that she's healthy. She can run 100 meters faster than me. She was super healthy. Okay, so if she then I had a few months ago a patient who came in with her BMI was about like 35, 40, and she had hypertension, diabetes, and she was 50. I said no to her because she was obviously not healthy. And if you were to get her pregnant, then it'd be unethical. Okay, so here the both couples were 52 and both were perfectly healthy. Okay, so I insisted they had undergo all the entire battery of tests, and they passed it with flying colors. Okay, so menopausal women, yes, they can still get pregnant because, as I mentioned, yeah, uterus is still functional. We just need to give them hormone replacement therapy, they'll be fine. Our donor egg program, we have only for non-Muslims. Okay, so like we have a Chinese couple, husband and wife Chinese, who want a baby, and she's already, most of the time it's really not menopausal or old age, it's usually the ones with premature menopause or premature ovarian insufficiency. Okay, where they lose their eggs at such a young age. So we get a donor age of 20 or 30 years of age. We have to follow their ethnicity. Okay, that's required. And then we will subject them to all these injections for 10 days, retrieve all their eggs, and inseminate with this patient's husband and transfer into a womb. Yes, that's what's done for egg donation cycle. And similarly for sperm donation cycle, we have the same ethnicity and the same profile as the husband. We have the sperm bank for them. Okay, can a woman with septate uterus? A woman with septate uterus can become pregnant, yes. There are certain procedures that we can do. Depends on what kind of septa they have. We can resect the septa for the patient, okay, and they can still conceive naturally. But and if you want to do IVF, one baby at a time, strictly no twins, because then they tend to lose their babies. What's the difference between your center and another center? Well, well, all the centers are the same, all doctors are the same, all want to make babies. Okay, for TMC, we have been around for quite some time, and a lot of first achievements we have done, and we have quite a huge network of clinics and doctors around. So well established for many years. Okay. How do we go for sperm donation? Well, you walk into my clinic and show me a report stating that you got no sperms. We'll have to confirm that first, okay? And then we will try. Then we'll try to find a similar profile like yours. Then we'll get you a donor, okay? Okay, oral hypoglycemic agents. I use metformin. Okay, there was a study called the MIG study. Metformin in gestational diabetes. This thing came out in 2007 or 2008. Okay, that proved that metformin is perfectly safe during pregnancy. A lot of doctors now have stopped using insulin. I don't use insulin for my antenatal patients. I will start them on metformin and monitor their sugars as usual, unless they fail to control their sugars with metformin, and then we start them on insulin. Honest, metformin is perfectly safe, no problems at all. Secondly, I also use metformins in patients which are having polycystic ovarian syndrome, those with high insulin resistance. Okay, we bring down insulin resistance with that, and I'll continue it at least 3 months into a pregnancy. There are actually 3 schools of thought for patients with high insulin resistance. 1, stop the metformin when they get pregnant. Okay. 2, continue throughout the pregnancy. 3, stop it at 12 weeks. Okay, so that's 3 things that you can choose. And for egg freezing, it's a bit more costly because you need to go through the entire process of injections and egg retrieval and storage. Okay, and the sperms is just simple. You just come in the clinic, give us a sample, and we freeze it for you. It costs about 1,000 a year. And as for the egg freezing, the whole process will cost you about 15,000 just to get your eggs to grow and freeze them. And it's about 1,000 a year maintenance fee. Yeah, and you can keep it till eternity, how long you want to. Okay, and non-transferable. Okay, can we become sperm donor? Oh, okay. Yes, of course you can become a sperm donor. So we need to ensure that you have the right age. Okay, and I'm not sure about the payment, but the last I heard was $150. Not very much. Yes, of course you can sell yours. That's not a problem. Okay, anyone with double degree, triple degree, you get a higher fee, I guess. Yes, of course you can determine the EDD from the IVF. There are certain calculations that we use, but the best way is to do your crown rump length. That's the best. Okay, because as you know, but more than 20% of women, even though those with regular menstrual cycles, the EDD will change. Okay, when you do the scans. Okay, and the best way to determine the expected date of delivery is the crown rump length. I've not seen anyone so far with embolism. I've read about it in journals before because of the high dose of estrogens, and those patients who had ovarian hyperstimulation syndrome and they had severe intravascular dehydration. Yes, it can occur, but it's very rare, and I've not heard it in my center so far. Okay, good question regarding traditional Chinese medicine. Okay, I believe traditional Chinese medicine has a role to play in certain patients, especially things like acupuncture, okay, where it relaxes the patient. A lot of fertility patients are very anxious, okay, and going for these traditional Chinese medicines, it calms them down, okay, and it also, some of the herbs, they have antioxidant kind of effect, so it makes the patient more healthy. So I have seen a patient of mine where she had done 2 IVFs in another center. I saw the reports, very poor quality eggs, and then I did an IVF too, poor quality again. Then she disappeared for about 5-6 months. She came back again and told me, "Doctor, come, let's do the IVF again." And the quality of eggs were fantastic. Then she told me she went for certain Chinese traditional medicine and she took some herbs and things like that. Okay, but it doesn't, just like in our modern medicine, you know, different people have a different effect. Okay, it's not 100% cure for fertility, or it helps all the patients. No, sometimes yes it does. How it affects, we don't know. But the theory is relaxation, antioxidative effect. That's about it. And like acupuncture before the embryo transfer also helps to reduce the contractility of the womb, and it helps in implantation. But that's not our mainline form of treatment.
Any final question for Dr. No, it's not.
Okay, that's it. Thank you very much, and have a good day.
Thank you. Thanks, Dr.